Here's a detailed, heading-by-heading explanation of the 15 differences between hypomenorrhea and hypermenorrhea, suitable for medical or nursing exam notes. 1. Definition. Hypomenorrhea is defined as an abnormally scanty or light menstrual bleeding that occurs at regular intervals but with a greatly reduced volume of blood. Hypermenorrhea, on the other hand, is characterized by abnormally excessive menstrual bleeding in terms of volume, although the bleeding occurs at the expected cyclic interval. In short, hypomenorrhea means too little menstrual bleeding, while hypermenorrhea means too much. Half 2. Amount of blood loss. In hypomenorrhea, the total menstrual blood loss is less than 20 milliliters per cycle, whereas in hypermenorrhea, the blood loss is excessive, often exceeding 80 milliliters per cycle. Normal menstrual blood loss is about 30-80 milliliters. Any deviation below or above this range indicates a menstrual disorder. Duration of menstrual flow. In hypomenorrhea, menstruation lasts for only 1 to 2 days, sometimes even less. In hypermenorrhea, the menstrual flow continues for more than 7 days or persists abnormally long each cycle. 4. Frequency of menstrual cycle. The menstrual interval in hypomenorrhea is usually normal, but in some cases, it may become slightly shorter if associated with polymenorrhea. In hypermenorrhea, the cycle interval remains normal, though it may occasionally become longer due to delayed endometrial shedding. 5. Nature of flow. In hypomenorrhea, the menstrual flow is light or minimal, sometimes appearing only as spotting or brown discharge. In hypermenorrhea, the flow is profuse and heavy, often soaking through pads or tampons, and sometimes requiring double protection. Clot formation. Because the flow is scanty in hypomenorrhea, clots are usually absent. In contrast, hypermenorrhea is commonly associated with passage of clots due to rapid bleeding that prevents complete coagulation within the uterus. 7. Common age group affected hypomenorrhea commonly occurs during puberty due to immature hypothalamic pituitary ovarian axis or perimenopause due to declining ovarian function. Hypermenorrhea is more frequent among women in their reproductive years, especially those between 30 to 45 years, when uterine pathologies like fibroids are common. 8. Hormonal causes. In hypomenorrhea, the main cause is insufficient estrogen stimulation, leading to poor endometrial proliferation and hence less bleeding. In hypermenorrhea, there is often excessive estrogen or prolonged estrogen dominance, unopposed by progesterone, resulting in excessive endometrial growth and heavy shedding. 9. Uterine causes. In hypomenorrhea, uterine factors include endometrial atrophy, uterine synechia, Asherman's syndrome, or tuberculous endometritis, which reduce the bleeding surface. In hypermenorrhea, uterine causes include fibroids, especially submucous, adenomyosis, endometrial hyperplasia, or polyps, which increase the endometrial surface and vascularity. Ovarian function. Hypomenorrhea is often associated with hypofunctioning ovaries or anovulatory cycles, leading to insufficient endometrial buildup. Hypermenorrhea may occur during ovulatory cycles, but with prolonged luteal phase or excessive estrogenic stimulation. Systemic causes. Systemic illnesses can affect both conditions differently. In hypomenorrhea, systemic causes include malnutrition, anemia, extreme weight loss, stress, or endocrine disorders such as hypothyroidism. In hypermenorrhea, causes include bleeding disorders like von Willebrand disease, liver disease, hypothyroidism, or hypertension, which alter blood coagulation and vessel fragility. 12. Psychological factors. Hypomenorrhea can be influenced by stress, anxiety, or emotional shock, which suppress the hypothalamic pituitary ovarian axis, reducing endometrial growth. In hypermenorrhea, psychological factors usually do not directly cause the condition, but may worsen perception of bleeding or fatigue. 13. Associated symptoms. Women with hypomenorrhea generally have no significant symptoms, although some may complain of infertility or short periods. Women with hypermenorrhea often experience weakness, fatigue, pallor, dizziness, and symptoms of anemia due to chronic blood loss. 14. Effect on fertility. Hypomenorrhea may indicate defective endometrial development or anovulation, leading to difficulty conceiving. Hypermenorrhea can also affect fertility if caused by uterine fibroids, endometrial polyps, or hormonal imbalance, which interfere with implantation. 15. Treatment approach. In hypomenorrhea, treatment aims to identify and correct the underlying cause, such as treating infection, removing intrauterine adhesions, or giving hormonal therapy, estrogen, progesterone, to restore endometrial growth. In hypermenorrhea, management includes iron supplementation, hormonal therapy, combined oral contraceptives or progesterone, and treatment of underlying uterine pathology. In severe cases, DNC or hysterectomy may be needed. Thank you. Have a nice day.